My name is Ron Montoya, and I'm chair of the board of the Latino Community Foundation of Colorado. It gives me great pleasure to welcome you to the Foundation's first annual forum, Telling Our Stories. Today's forum complements our new vision of playing a greater role in the community by convening people and discussing critical issues that are pertinent to Latinos and that allow members of our community to reach their full potential.
Well, it's really a pleasure to be with you here today in your beautiful state and this beautiful city. And I really mean that. It's really a beautiful place to be, is Colorado, and it's one of the really nice places to be in this country. I also know that your work is so important, and I know that you need very few lessons and instructions about how to do the work you do. You're so experienced in it, and you're involved in very important endeavors that are quite complementary to each other as I meet more and more people who are here today. I think that's always, our major goal, isn't it, to try and figure out how we can work better together and how we can do a more effective job of bringing the change that we want to bring. I'm going to actually be speaking to you about issues that have to do with how we think about health and Latinos and the situation that they are facing in the United States today. We know that the issue of health is a complex one, and I'm going to spend a certain amount of time dealing with big ideas about what's going on in the country right now in relationship to Latinos, and also how it comes down to the issue of what you really see every day in your work here in Denver and in Colorado. So, as we move ahead with that, the aims of the presentation are to understand the Affordable Care Act as a rational approach, not a baked cake, a rational approach, because that's what it is. It wasn't something that people thought, oh, we have the final version here, it's going to work perfect. It was a strategy. It's an approach to reform. And it's going to have many mid-course corrections before we ever get to the point where we say, gee, this is really great, and it just accomplished all the things it wanted to do. The scope of the Affordable Care Act assumptions and the implementation strategies are really about improving population health. It's not the prime goal to get people into having access to primary care or something of that sort. It's about improving the health of the nation, reducing the burden of disease. And this has everything to do with people who are, of course, over 60 and beginning to face stages of life in which they'll have more and more unfortunate victimization by disease. So what we're trying to do is really think in terms of how can we make this a healthier nation, and the healthcare piece, a critical piece of that, but not even the most important piece of that. All right, I want to make that absolutely clear. And how do we meet this challenge for aging Latinos and for other vulnerable groups, because there are certainly other vulnerable groups in the country. And we can't make attaining the perfect healthcare system the enemy of establishing a good and workable healthcare system where we improve access to care and quality of care. So I want to make clear one thing, that we talk a lot about disparities in health, and I think that you have to understand that there's really two great arenas in this world when we talk about disparities in health. One has to do with the actual disparities in health because there's excess disease in certain populations. That is one kind of disparity. An entirely different kind of disparity, although it's related, is the question of disparities in health care. That is to say, are people getting equal quality of care when they actually go for care, which is a very different question. You might not have a problem in terms of a disparity of health. For example, Latinos do not have excess death from cancer. They actually have lower cancer rate death. Nevertheless, they get lousy care. They get no care or they get bad care and in the main. So the question becomes, all right, then how do we improve the latter so that people can live longer? Because the one thing we know is that if you needed the quality access to care situation resolved, it's especially true when you're over 60 years of age and moving on, and when people are going to be living to 70 to 80 and to 90 and going on into 100 years of age, increasingly as we go over the next 20 to 30 years with the great controls that we're getting for self-management of disease and the effectiveness of newer medications. It's going to be a common problem, but the problem is going to be having quality of life that results from all of this. So the bottom line is I'm making the point that this is a 20-year train ride that we're on right now to try and coalesce these various things that we're doing in healthcare, in community work, all along the line here so that we begin to see fusing and focus coming to the work that's going through the circuits of what you heard here this morning right now in building communities, building strength in communities. And of course that means building a solid social component to our citizenship in this society. which means education, social mobility, taking your place in the society, having leadership roles, etc. And it also means, as part of all of that process, that we're going to be able to straighten out many of the complexities of putting together systems that were never designed to work with each other in the society. So it is a great challenge as we move forward. And as I look at aging, I think that the critical issues really are built in stages, and they're quite discrete at this stage in time, and more I think they're going to have some reflection and connection with each other. So we're really talking about, as we heard this morning, improving communities and their health. As we improve the quality of communities, we will improve the health of those communities. The integration of services, because clearly services in the health side and the medical side, et cetera, are not well coordinated in the past, and they need to be much better coordinated, especially in aging. And then, of course, re-engineering pension systems, because they're so woefully inadequate. I mean, the average amount of money given to a person who's worked for 40 years, average Latino or African American in this country, is $1,000 a month. Well, I mean, that might work in Alabama, but it does not work in L.A. And in L.A., you can't get one room for $1,000. So, how are you going to live on $1,000? And, we do increasingly have more and more people living alone. 25 to 30% of people over 65 are living alone, including Latinos. Less and less can we depend on the old classic situation of, all the generations will live together like on the rancho in Mexico. That's just not happening, So we have to figure out, all right, how do we develop pension systems that are somehow more equitable than they are right now? Because medical doctors at the medical school who are millionaires when they retire still get high-end payouts on Social Security of $30,000 a year, and others are getting $1,000 a month that have nothing to turn to besides that. So as we move on from discussing, and of course, viable long-term care. Viable long-term care, we all know about that one, and that's an absolutely critical one because we don't have it. We don't have it for people that can't afford to pay for the insurance up front, which is expensive. And we thought we were going to have it in healthcare reform. Remember that? We were going to have that special program that was going to be inset in there. You were only going to pay $50 a month if you were low income, and you were going to have long-term care. But that went away because it could not be an entitlement program. It had to be a program pay-as-you-go, and it just wasn't fiscally viable. So I want to tell you that I did take some time to look at the state of Colorado before I came here to see how similar it was to the situation in California. It's very similar, actually. I was really surprised. You see a population that is approximately 21% of the population. Of course, in California, that is much higher, but the median age is about the same, around 26. The median annual personal earnings, $22,000 a year in today's economy. So we know what that means. We know what it means structurally. We know what it means in terms of opportunities for education, et cetera. And we know that the poverty rate of 31% is a standard across this nation for people under 17 years of age for Mexican origin. That's just the way it is, and it's very similar for African Americans. Without health insurance, about 27%. Actually, I think that is an exceptionally high, let's put it this way, that's exceptionally good performance for the state of Colorado, because in California it's much higher than that even today. It's about 39% right now in California, even with ACA, because we have so many undocumented immigrants in California. Home ownership, 47%, something you see routinely among Latinos as well. Even though they don't have much money, they have homes, and they buy them, even if they're not expensive, but they fix them up and they live in them. This is harder and harder to do in many states because of the cost of property and income and the low salaries. And the systematic inequality that we've been producing since 2004, 2005, and we've come out of this situation with a real problem in adequacy of income. And the percent of all K through 12 students, of course, 1 in 3 or more or less, and that's going to continue to get higher. That'll be 40% quite soon, I'm sure. So here is the actual national data on the median worth of households by race and ethnicity, 1984 to 2011. So you can see what has happened is pretty much stagnated along the bottom. African Americans very similar, and they end up in exactly the same place just about. This is their total net worth here in terms of median net worth assets. 6,004 and 7,800 versus the white population of the United States, $91,405. So you can see what we're talking about. I actually have another one that shows it's slightly better for people that are over 69 because they've accumulated the assets through their home. So these are sort of passive assets because they're in their homes. But you can see it's still different. I mean, African Americans, Latinos have these much higher levels of income over 69 than they do earlier in life, but it's still far different than what whites have. And the whites also have the situation where through the earlier years, 49 to 68, they also had high income, so which means obviously they're in a much better situation in terms of having a home that's more likely to be paid for or close to it, or assets and investments, et cetera. So there's quite a different situation going forward to the silver years, all right, when you go in and you're vulnerable, you're feeling vulnerable, and you're wondering how you're going to handle any of the great emergencies that you can anticipate coming in your life. So we know that much of the problem in the past has been rooted around the issues around residential segregation and racism, institutional racism, problems that we're trying to work ourselves through, whether it's through the courts or through other means. The Affordable Care Act is attempting to overcome many of the disparities that have come forward in the health area. But we know that these situations continue to persist, and they're really difficult ingrained problems at the root of everything that we're talking about, because such things, for example, as segregation and redlining mean that people end up in districts in which the school districts are vastly inferior. We have very high school dropout rates, non-completion rates. And really, the education is poor to the point where in grammar school already, in elementary school, they're already doing badly enough that they have very little hope of doing well as you get to the more complex subject matter in middle school, and then they're completely out of it by the time they get to high school, and we have these high dropout rates, the non-completion rates. We have to get past that problem. If you look at the structure of America with increasing Latino and African American Asian population, they're going to take over America past mid-century in terms of driving the future of the country. You have to have people who are going to be well educated and replace the income, the revenue streams that have been there traditionally from other populations that are now retiring. So who's going to replace those populations? Who's going to be able to supply that makeup in the income? Well, well-educated people have to do it, and they need to come forward. They are coming forward, but just not fast enough. I mean, in California, the majority of people in the California State University system that are applying for and actually getting in, not the University of California system, but the California State University, San Diego State, San Francisco State, those schools, are Latino names, surnames. And good, because they reflect that. But in the UC system, very little. I mean, it's really hard to see any representation of Latinos and African Americans in the UC system, in leadership roles, and in medical schools, and in university professor roles. It's just not there, not even now, with this massive population that we have. So, it's a long way to go there. At the same time as I say that, the good news is, and this is just data from LA, to give you, it's very similar to the national data, and I'm sure what you'd find in Colorado as well, that actually is a very good story to tell, because over the decade from 1999 to 2009, we've seen decreases in mortality from all these major killers. Coronary heart disease death has gone down by 42%, stroke by 41%, lung cancer by 23%. Down here, colorectal cancer, liver disease, all of these have done well. Homicide down by 33%, HIV/AIDS death down by 50%. So we've made progress across all the populations. It's just that the disparities in the areas in which there are differences it's sustained. For example, in diabetes, there's excess mortality for diabetes among Latinos. It has sustained, even though we've had an overall decrease. So what's happened is everyone has done better managed, including the chronic diseases are better managed, but the outcomes are still not so good. So, but the bottom line is, as you get this, you also get this. That's not a 94% decrease. That's an increase. So what we have is people living longer, but they're living longer with dementias, with Alzheimer's specifically, and of course we have a whole bunch of other problems associated with these later stages with management of diabetes, heart disease, et cetera. So, this is a complex picture, and it does mean that we have a burden coming forward that needs to be better managed holistically, organically from the community level forward, better self-managed within families, because there's no way that the medical system can ever take care of this. The shortage of doctors, the shortage of capability financially to deal with a situation that's totally put on the medical system, it's simply unworkable. So we simply have to regenerate society and regenerate our communities. Now, we've done a number of studies in my group and other groups as well around the issue of what happens in older age. And what we see with Latinos is fascinating, because they live longer than whites do in the United States, actually. I mean, they have better health outcomes, that paradox phenomenon that they actually live longer. Most of that is attributable to lower smoking, by the way. People wonder, where does it come from? Well, smoking in Mexico among women is very low, almost non-existent, and it's very low among men too. So what happens when they come to this society and over the years that they've never really picked it up to the same level. So that has an enormous beneficial effect in lowering cancer rates, COPD rates, and cardiovascular risk rates. So they actually, even though cardiovascular is still the major killer in all groups, it's less likely to be as high in Latino groups because of the fact that they don't smoke. So you get a beneficial effect. People live longer, but the accumulation of all of those years in poverty, difficult occupational situations, etc., ends up having a cost at the end of a lot of disability and a lot of multiple illnesses that have to be managed somehow by somebody. And in many instances, it's by people who are in this audience right now that have done this and are doing this right now, helping loved ones manage these conditions. So the fascinating thing is when you look at the expert opinion, and believe me, this is some of the best, I think, people who have ever thought about this issue, of attributing the importance of different determinants in society to what produces health. You look at 4 basic sectors. One has to do with our behaviors, because we know our behavior produces good and bad health, how we eat, if we exercise, the issues around how much alcohol do we use and drug use, et cetera, all of these things. These behaviors are voluntary behaviors that we get ourselves into, and we do them or we don't do them. Those are important determinants. Clinical care, of course, medical care is important. Social, economic factors are important. Physical environment. So these are the 4 great domains that they're looking at that we think need to be modified through public policy, through health policy, social policies of various kinds. But the fascinating thing is, look at the contribution levels that they give to each of these. About clinical care, medical care, they believe is responsible. This is at the national level. About 20% of all health is produced from medicine. Immunizations, self-management of chronic disease through medical guidance. But 40% of it is produced through social and economic factors. In other words, inequality is producing a big part of the health problem. And the issue of producing better health has much to do with getting better educations, better income, and producing better communities in the process. Health behaviors is seen to be about 30% of that, and it's of course influenced by the socioeconomic factors as well. These are obviously related. And the physical environment is seen as about 10%. In other words, the toxicity of the environment you're actually living in, and how well that environment really supports health. So the bottom line is that even though the Affordable Care Act is important, nobody in Washington who produced the Affordable Care Act ever believed that better health care was going to produce better health in America as an overwhelming effect. It had to come as a stage of coordinating other elements in the society and all the way to the community level. And that's why a lot of the effort has gone under affordable care to CDC, to the Center for Disease Control, to put money out to communities in order to better the possibilities of addressing at the community level issues around food supply and its quality, to the suppression of tobacco use, and all these other issues that are associated with basic community health. So the efforts now are really very holistic in trying to understand how the pieces fit together. So the roles that many of you are engaged in right now are right down that alley. That's exactly what many of you are doing. And I think it's exactly where we have to go with what's going on now. Now, the connectedness between the pieces is where these are all arenas that are difficult because we're dealing with a situation, as I say here, how much can we improve health and healthcare without a corresponding increase in income and education? Because in the short haul, in the Latino community, we are not going to make an astronomical leap over the next 20 years in the education and college completion rates in this community. We're going to make an increment. But we have this influx of the immigrant population with very low education levels is going to be very stagnant. Their intergenerational change is going to be very low at this point because there are no mechanisms to move that group forward. What we have right now is the second and third generation that have more assets in the Latino population, and they are getting educated, and we're seeing that. So it is an intergenerational process. Speaking of generations, is 20 years. So as I see it, right now for the time being, we're operating against the current for a spectrum of our population that is the least advantaged. And we have to think in terms of setting targets for how to show improvements. Given that set of disadvantages, how do we set targets to see that health status issue move up? Because we know it can be done to a certain extent. We can't create a situation of overcoming completely the differences in economic inequality and the impact that has on health. But we can do a lot of things to improve the quality of health and give people more opportunity for a good life. How do we design and implement social care support systems in the case of elderly people to reduce the need for health care by preventing treatable problems and controlling these chronic conditions? That's really the main charge right now. So aging in place, I mean, we all know people want to live in their own homes. They don't want to be put in an institution. You know, we know that they need to have certain basics. They need to have a home that you can live in that's safe. We need to have streets you can walk on without falling over them. Like in LA, I go for a walk, and this isn't a nice neighborhood. I mean, if it's dark, you're going to fall over because the streets are all uneven and so are the sidewalks. So I see people flipping over all the time in my neighborhood, and you wonder, why don't they fix, how the roots lift up all the sidewalks? And the city doesn't have the money to go put all new sidewalks and tear out all those roots. So you just got to keep falling over, or pay attention, And the whole issue, even getting across the street, on Wilshire Boulevard in Los Angeles, you got 20 seconds to get across that street. I see people take 2 changes of light to get across the street. And I'm just holding my breath that somebody's going to run them over. I mean, there's such anxiety. I mean, that's, 20 seconds in LA to have to wait for somebody to cross the street is like a year for any normal person outside of LA. It's like the most anxious, crazy, thing that you've ever seen in your life. So, current practices in human services and public health have not produced a situation where people who are aging and disabled can really live comfortably in their low-income situation. So we have to think in terms of how are we going to produce that kind of surrounding, sustainment, of resources that can be provided economically. It really, as much as possible, comes from organic sources in communities themselves. So the difficulty really is coming in organizing these 3 great worlds: the community context where we live and where we work, social support, families, health, medical, and social services, and putting these together in different combinations that really work to improve the conditions of our population. So the ultimate challenge will be to functionally integrate these levels and establish these initiatives that foster community and resident participation and advocacy. So I think that you're all involved in that, so I don't have to tell you too much about that. I think you have a good sense of that issue. So the bottom line is, I think that community participation is going to be needed, and it's being pushed hard now by health agencies, but we're not quite to the point where we actually have an active model of knowing how to do it, because the transformation under affordable care has come so recently that we're not really there yet. And we're still operating, trying to figure out, how will all these big organizations like healthcare organizations, the privates and not-for-profits, how are they going to engage the community? How are they going to help in self-management? How are they going to help in home assistance? They have the responsibility to do it, to a certain extent at least. And so the question of how they can do it in a way that they've never tried before. And the public agencies, how can they come into communities and do the most effective job when they have always operated on the basis of reimbursement for developing only clinical care programs, not for going to the basic social determinants of inequalities in health? And now they're trying to do it. They're trying to figure out, how do we go about doing that? Where do we touch the community and try to operate some mechanisms or engage with community partners and do this in a way that will make sense? This is the exciting creative opportunity that's before all of you, I think, at this point. Now, we know our communities, this is East LA. Look at the freeways strangling East LA, okay? And they've got playgrounds and schools and everything right next to all this toxic nightmare that's going on. And this is all of the trucks that come through from the port of Los Angeles that are coming to the western part of the United States for distribution, stuff from China, of course. It all comes through here, all that particulate matter just floating into these communities, the high toxicity. They should never have built any of that stuff to all these playgrounds next to the freeway, but they did it. And of course, those freeways cut off, as happens here in Denver as well, cuts off the community from the downtown complex and, of course, the rest of LA. So, it sort of shunted off, to one side, and it creates that barrier that has always kept East LA as sort of a world unto itself. It's 97% Latino in East LA. So, one of the great opportunities is here through the community transformation grants I told you about earlier from CDC, that is trying to push money into our communities through public health agencies to deal with these core issues. That's a very important push, and I feel terrible that they've left universities out of this. In some ways, I think I understand why. They figure, you got NIH, you can do your research over there. But these are being done very quickly, and quite often without the benefit of the ability to evaluate them appropriately or to do research on them to determine what's their impact on current public policy and health policy in the country. We really need to have that linkage, because I don't want to see a return of what we had in the back in the war on poverty days, when we had a lot of money pushed out, a lot of programs took place, no record was done, no evaluation was done. We don't even know what worked and what didn't work. We can't have that again. We can't afford to have that again. We need to use this to bring the ACA, the whole transformation of these communities through better health, to be organically done and clearly learn from our lessons when they fail and learn from our lessons when they succeed. And we also need to, I think this is very clear, that across the nation, people are more and more using assessment tools, simple assessment tools to identify indicators for your community and then look at them like report cards. Look at the Latino community. What are the issues that need to be rectified? How are you doing over a 10-year period to change those things? Simple tools that go to policy, that go to program people and say, look, this is what's going on. You have not made progress here. You've made good progress over here. So let's shift the burden to something else. So we'll learn tremendous lessons by simply being aware and taking quantitative metrics on things that we are changing and not changing, and looking at hardcore measures of access to care, at health itself in different ways, whether it's youth or whether it's people who are adults or whether it's aging people. Because after all, the youth will become adults and will become aging people, and they will ultimately be the final point of all those previous experiences across the life course. Now, Donald Berwick is, I believe, the best probably health services person in the country, researcher, policy person. He was one of the people who designed some of the early stages of the Affordable Care Act, not the way he would have wanted it, but the way at least he was part of that process. He had this wonderful statement that I always use when I talk about these kinds of issues. Every system is perfectly designed to achieve exactly the results it gets. So I know all of you worked in systems, and you know exactly what he's talking about. You know, everyone has a hand in the pie of any particular place. So in Denver and in Colorado versus Texas versus Alabama versus California, there's going to be a very different version of what comes forward as the process 20 years from now of what the Affordable Care Act came out to be, how it was able to move forward and actually deal with the issues, the complexity of uniting these various sectors together for a common purpose. And I think to that end, you know, when you look at a kind of framework for understanding this in the arena of healthcare, clinical care, and community-based care that goes from clinic to home, these are the kind of levels that we have to be concerned about. And I think that on the side of uniting social services with medical care services, we have to think in terms of, okay, what are the critical health issues in our communities? What are the subsections of the vulnerable populations that need to be more carefully addressed? What are the measures that we need to look at over time, just like I just mentioned? And what are some of the facts that make our community unique? And then understanding, you know, what does this really mean? You know, from the standpoint of populations that have, for example, the Latino population, many of them have never made it into care. We have a huge portion of the population that has never had a regular provider, a regular health provider. We have a huge portion of the population that's never had preventive care. Now they're showing up, you know, with the Affordable Care Act is showing up for the first time. Well, they've got a lot of issues that they're going to have attended to very quickly. So the question of understanding the individual patient needs and how to, in fact, improve the quality of the clinical encounters so that people understand what's going on in the clinic. They can find the next stage in their care when they're referred someplace else. They can understand the instructions from a physician. They can understand, and the patients can, the healthcare system itself can understand, and the physician can understand that they can't afford that medication. So how are they supposed to do that? You can't ask them to do impossible things and screen them out, you know, right from the front end. And so you go through these processes of beginning to learn the populations and the new ones that are coming in, and learn how to work them more effectively, for example, with the language breakdowns and the problems associated with just basic understanding of information. And of course, ultimately on to intervening in the process to change those processes of care. So I want to move this on because I know I'm basically just about out of time here. So I'm going to move it to, this is a bunch of very dense things I'm not going to do because I don't have time to do them. So but I'm going to go back to this one here. Let's see, not that one. Yeah, this one. How do we get there? Clarifying national aims for improvement, changing the care itself, changing the organizations that deliver care, and changing the environment that affects organizational and professional behavior. All of this has to be done. This is the charge in the healthcare system. And I think they're taking it fairly seriously. The difficulty comes in accountability, because we're talking about systems that have never been used to dealing with the mandate of really being responsible for the results of their care. They just physicians give you care, and in the past, you kept paying for your care. And if you didn't get better, you paid for more care. And you went to another doctor and got more care. Now, you have to be responsible for producing results. And difficulties of barriers in cultural differences in language, etc., are producing systematically, we know very well, bad results. The national report shows 75% of the indicators that they use for Latinos and quality of care are negative ones. It's worse than any other group. 75% negatives on the indicators that they use for standard assessment of quality of care. Those have to be changed fundamentally and basically. And we still have 41 million people right now who are not insured. Despite the ACA first stage involvement, of course, it's only been going for a little while, but we still got 41 million people. And of course, the most affected population are Latinos because there's such an undocumented group in there that does not have access. They can't get it. So what are we going to do about all of that? That's still there as a residual unsolved problem of access and an unsolved problem of quality. So, it's not going to go away. It's not that they're all going to end up they're not going to end up at the emergency room. We know that. We've done studies nationally on this, even though despite all the negative publicity, Latinos are not ending up in emergency care for their care. They don't overuse it. In fact, they, compared to national averages, actually underuse it slightly. But it does mean that they're going to have to go to health, these gigantic health, in LA we hold one at the sports arena, these big health fairs. 10,000 people come in to these health fairs. The thing that they want the most, guess what? Dental care, right? The level of lost teeth among 50-year-old Latino immigrants in this country is shocking. And we've always played the game that your mouth and your teeth have nothing to do with your health. They have everything to do with it. And they have everything to do with your self-esteem and your ability to enjoy a social life and social experiences and get employment. I mean, it's crazy that we've always segmented teeth out as if they didn't count. So, for me, I mean, it really is a telling tale when you see the sports arena photographs and you see the place full, people going with occupational injuries and everything else, they can only be seen for one day there. But right in the middle are all of the dental chairs, and that's the busiest action is right there. Right there, and also vision stuff. Those are the two big ones. So we still have this residually. And we don't want to see this in children. We don't want to see, and of course, it's least likely in children because they tend to be covered. But still, the question of getting families healthy, keeping intergenerational family healthy, where we're going to see aging people increasingly having to live in these multifamily situations when they don't have any resources. It's the place of the last resort. So we know that we really want to have healthy families, healthy practices, et cetera, and a healthy community for people to have intellectual stimulation, social stimulation, recreation, the ability to have transportation accessible. These things are the basics that everyone in the community will benefit from, and ultimately health will be vastly improved. So despite the great challenges of inequality, which are not going to be easy ones to overcome, and that's a whole other policy discussion, we, I think, can do many, many things to improve the quality of life for low-income Latinos in the country, and especially for those who are aging who need, this kind of improvement in their situation the most right now. And I have to say that overall, I mean, Latinos do live long. They are fairly long-lived, surprisingly, given the ordeals that they have been through in their lives quite often, but they live with an enormous amount of burden. And that burden is passed on to their adult children who must contend with it. So it's not a fair situation, but it's life. And I think we can do a lot from the standpoint of increasing opportunities for everyone to live well and to be able to give a much better chance for people to have those longer extending lives up to 85 and 90 years of age as a routine practice, even in the circumstances of low-income communities, if we deal appropriately with the conditions in those communities. So I'll stop there because we're going to have a conversation about these types of issues, but I certainly welcome any questions that you have later on.